Our topic for this lecture is cerebral aneurysm, and we'll be meeting our level 1 and level 2 objectives for the DMS program. Brain aneurysms are a focal dilation in the cerebral arteries. They can occur in about 3 to 5% of the U.S. population, most commonly in the 3rd to 6th decades. Females are affected more than males, and they're usually small. They're usually under 2.5 centimeters, and they can have some different appearances you will see in radiography or neurosurgical descriptions as saccular or berry aneurysms. They're most commonly located along the middle cerebral artery or the anterior cerebral arteries, and less commonly, but you will see them along the communicating branches in the circle of Willis. So when we talk about cerebral aneurysms, we are always talking about the circle of Willis. The most common risks are hereditary connective tissue disorders or a family history. So we do know that there's a genetic connection in first-degree relatives. Of course, hypertension, cigarette smoking, and septic emboli can actually cause mycotic aneurysm. They kind of create this outpouching as well. Symptoms and signs will correlate to the compressing adjacent structures once they're big enough. So most of the time these are asymptomatic. People live a normal life. They have no idea that they even have these unless they bleed or they become large enough to compress that adjacent structure. Once they rupture, this is a neurosurgical emergency. This will bleed into the subarachnoid space. So this is that thunderclap headache that we read about. This is an acute, severe headache. Massive amount of blood flow into the subarachnoid space will cause massive headache, nausea, vomiting, or you can get blood into the ventricles, so you can end up with nuchal rigidity, photosensitivity, but again, often with loss of consciousness. Some people will get a sentinel headache. This is kind of a warning headache. Prior to rupture, they will present, this is a weird throbbing headache. I have never experienced this before, and if they're lucky, you'll pick up on it and hopefully intervene before that ruptures. In terms of diagnosis, neuroimaging requires angiography, CTA, or MRA if they cannot have contrast, can be done, but CTA, so CT with angiography, is a gold standard for diagnosis. In your larger centers, neurosurgery can do direct cerebral angiography. MRA, so no contrast is needed, but this is a reconstruction of the brain vessels, not a direct flow. If mycotic aneurysm is suspected, which you'll probably have a underlying suspicion for because they're going to look sick, you're going to obtain blood and fungal cultures. As far as treatment goes, for a very small asymptomatic aneurysm, you can do serial imaging. So you will have referred this person to neurosurgery and they will make their recommendations because very tiny ones, under 7 millimeters in general, and if they're in the anterior circulation, they're at low risk for rupture. We want to control other atherosclerotic risk factors, so they need to stop smoking and get that blood pressure under control. Treatment will be based on the size, location, the risk of rupture versus treatment complications, because of course they can rupture during treatment. That's a very high risk surgery. We also want to take into consideration the patient's age, their general health, and then their family and medical history. Again, their risk assessment is going to be key, and the neurosurgery team is going to be helping make that decision. If this is a large bleed, or if it's posterior, treatment involves going directly for emergent endovascular therapy versus open surgery with neurosurgery. If this is a small hospital, they're going to be emergently transferred for intervention, and hopefully they make it to the next hospital. Mycotic aneurysm, these are going to be treated with aggressive antibiotic and antifungal therapy, but these do generally need repair. These are at fairly high risk for rupture.